Welcome to this deep dive. Today, we're tackling something we all see pretty frequently in primary care, managing type 2 diabetes when the oral meds just aren't doing the job anymore.
Right. Specifically, we're looking at initiating basal insulin. It's a really common scenario.
Exactly. And it's, crucial for providing good care, especially for you residents out there navigating these complex cases. So we thought the best way to unpack this is through a typical patient encounter.
Makes sense. Let's dive into a case. We'll call him Mr. Tan. His situation, I think, will feel very familiar. We can use it to pull out those key clinical pearls around starting basal insulin.
Okay, perfect. So let's imagine we're in the clinic. Mr. Tanwiling is here for follow-up. He's 58, drives a taxi, and his type 2 diabetes control, well, it's not great. Mr. Tan, it's good to see you again. I see your recent HbA1c is still quite high at 9.2%.
Yeah.
You mentioned you were worried about this. Just a quick reminder for everyone, HbA1c gives us that 3-month average blood sugar picture.
Doctor, yeah, my sugar levels are still high even though I'm taking my pills. My last check was bad. I'm really worried I might need insulin injections, like my uncle.
Okay. You're currently taking metformin 1 gram twice a day, is that right?
Yes, that's right.
And how often would you say you're actually able to take it?
Well, sometimes I forget because I'm driving, or I skip it if I haven't eaten much because I worry about stomach upset. I probably miss about 4 or 5 doses a week, mostly the lunchtime one.
Right. And you were also on gliclazide before, but you mentioned you stopped that. Can you tell me a bit more about why you stopped?
Oh, yes. I stopped it maybe 2 months ago. I felt dizzy a few times, usually late morning, especially if my lunch was delayed. Really felt like I was going to fall, so I stopped taking it.
Okay, understood. Could you maybe describe what you typically eat in a day?
Usually at hawker centers or coffee shops because of work, you see. Breakfast is kopi and kaya toast. Lunch, usually mixed vegetable rice, often with fried stuff, and always white rice. Dinner is, similar, or sometimes noodles. And I drink another couple of kopis or taterics during the day. I don't really eat fruit or whole grains, and my rice portions are probably quite big, yeah.
What about exercise or physical activity?
No, not really. I drive for maybe 10, 12 hours a day, 6 days a week. Honestly, I'm just too tired after work.
Do you ever check your blood sugar at home?
I have a glucometer, yes. But the strips, they're quite expensive, so I don't use it very much.
Okay. And do you have any other medical conditions, like high blood pressure or high cholesterol?
Yes, I was diagnosed with high blood pressure about 10 years ago, I think, and high cholesterol 5 years ago.
And do you remember the names of the medications you're taking for those?
Yes, I think it's amlodipine for the blood pressure and simvastatin for cholesterol.
Okay. You mentioned your uncle had diabetes and needed insulin. Was there anyone else in your family with diabetes or related issues?
Yes, my father had diabetes and high blood pressure. He died of a heart attack. My mother has high blood pressure too. And my uncle, the one with diabetes, he went blind and needed dialysis after he started insulin. That's why I'm so worried, doctor.
It certainly sounds like you're quite concerned about your diabetes and especially about this possibility of needing insulin.
Yes, I am. Very scared of needing insulin injections. My uncle, he had such a terrible time. Will I lose my driving license if I go on insulin? And how can I afford more expensive treatments? It's all very worrying.
Okay, Mr. Tan, just going to do a quick physical check now. Your blood pressure today is a little high at 148/92. I also noticed some darkening of the skin on the back of your neck. We call this acanthosis nigricans. And it can sometimes mean your body isn't using insulin very well. And when I check the feeling in your feet with this special filament, it feels like the sensation is a little bit reduced. So just to summarize, Mr. Tan, it looks like the type 2 diabetes isn't well controlled right now. And there seem to be a few things contributing, like not always taking the metformin, stopping the gliclazide, the diet, and not getting much exercise. We also definitely need to address the blood pressure. And importantly, you've told me you're really worried about starting insulin.
Mr. Tan, we need to address a few things here to try and get your blood sugar back on track and, reduce your risk of complications down the line.
Okay, let's pause the role play there. This is such a classic primary care scenario, isn't it?
Absolutely. So many overlapping issues.
What are your first thoughts? What really stands out to you as the key things we need to tackle with Mr. Tan? Well, the first thing, definitely, is the medication non-adherence. And crucially, why he's non-adherent. It's not just forgetfulness.
Right.
It's his work schedule. It's the side effects he's worried about with metformin. It's the side effects he experienced with gliclazide.
Exactly. That's a huge clinical pearl right there. Always dig into the why. Don't just assume. Telling someone to take your pills isn't helpful if we don't address the barriers.
And the gliclazide cessation. Him stopping it because of dizziness, that immediately screams potential hypoglycemia, doesn't it?
It really does. He likely had low blood sugar because the gliclazide was pushing his insulin release, but his meal times were erratic due to driving, so when lunch was delayed...
The sugar wasn't there, and he felt dizzy. Makes perfect sense.
Right. So another pearl. Always ask about side effects and how patients are coping. Stopping meds without telling us is common, and often there's a reason we can help with.
Then there's the diet. So typical for someone working long hours, relying on quick, convenient food. Hawker Centers, Copy.
Yeah, the high refined carbs, the sugary drinks, it's a major challenge. And just saying eat healthier is, well, useless advice usually.
Right. We need practical, culturally relevant tips, like suggesting swaps at the hawker stall, maybe ask for less rice or brown rice if available, steamed options instead of fried, kopi o kosong instead of kopi.
Exactly. Pointing them to resources like Health Hub, which has visual guides like the plate method applied to local food, can be really helpful. Small, achievable changes are key.
And the physical inactivity tied to his job. That's a tough one.
It is, but maybe we can explore small windows. Could he walk for 10 minutes during a longer break, park a bit further away when he stops, use his day off for some light activity? Even minor increases help.
Okay, let's tackle the elephant in the room. His fear of insulin. That story about his uncle is powerful.
Absolutely. And the first step is just acknowledging that fear, validating it. It sounds like you had a really worrying experience seeing what your uncle went through. Start there.
Empathy first.
Then we can gently start to address the misconceptions. Explain that, unfortunately, complications like blindness and kidney failure are risks of poorly controlled diabetes over many years, not usually a direct result of starting insulin itself.
Right. Sometimes insulin is started because complications are already developing, or the diabetes is very advanced, which might contribute to that perception.
Precisely. We need to reframe insulin. It's not a punishment or a sign of failure. It's often the most effective tool we have to prevent those complications when the body's own insulin production decreases, which is part of the natural progression of type 2 diabetes for many people. It's about regaining control.
He also raised very practical concerns, driving and cost.
Yes, and we need direct answers. For driving, the key is stable control and education about managing hypos. Taking insulin doesn't automatically mean losing his license. We need to reassure him based on the actual guidelines.
And cost.
We should acknowledge it's a valid concern. While we might not know every detail of assistance schemes offhand, we can say we'll look into options or refer him to a medical social worker if needed. Just showing we hear the concern is important.
So given all this, what's the initial management plan? We probably wouldn't jump straight to insulin today, right?
Probably not. The first step is optimizing the current situation. So number one, really work on that metformin adherence. Brainstorm strategies, phone reminders, pill boxes, linking it to brushing teeth, whatever works for him.
Okay. Then what about the glycoside he stopped?
That's a tricky one. We could consider reintroducing it at a very low dose, maybe just once a day, but only, and this is a big only, if he agrees to regular home blood sugar monitoring and receives thorough education on hyposymptoms and management. The 15-15 rule, 15 grams carb, wait 15 minutes, recheck.
And if his meal pattern stays erratic or he's resistant to monitoring, maybe glycoside isn't the safest bet.
Exactly. The hypo risk might be too high in his case. So alternatively, we should definitely discuss adding a different non-insulin agent.
Like an SGLT2 inhibitor or a DPP4 inhibitor.
Yes. They work differently from glycoside. SGLT2 inhibitors help pee out extra sugar, and some have those great heart and kidney protective benefits, very relevant for Mr. Tan with his hypertension history. DPP4s enhance his own insulin release, but mainly when sugar is high, so they have a lower hypo risk. We discussed the pros, cons, costs.
And we absolutely cannot forget his blood pressure. 14,892 is too high.
Definitely. Reinforce adherence to the amlodipine. We likely need to increase the dose or add a second agent based on guidelines, and get a repeat lipid panel to check if his simvastatin is adequate.
Home blood sugar monitoring feels essential moving forward, whatever we do.
It really is. Even if he starts with just a few checks a week, maybe fasting and before dinner, it gives both him and us valuable information. We need to explain why it's important, despite the cost of strips. Maybe explore if there are ways to make it more affordable.
Okay, so lots of things to try first. But when do we start seriously considering basal insulin, based on the guidelines?
Well, the ACE guidelines suggest considering it if we can't meet the glycemic targets, say, that HbA1c stays stubbornly high like Mr. Tan's 9.2%, despite trying these other non-insulin options optimally. Or if the patient has significant symptoms of high blood sugar, like losing weight without trying, extreme thirst, frequent urination, that might push us towards insulin sooner.
So Mr. Tan is definitely in that territory where we should be thinking about it as a likely next step if these initial changes don't work.
I'd say so, yes. We need to prepare him for that possibility.
And if we reach that point, if we decide basal insulin is the way forward, what are the key practicalities we need to cover?
Okay, first explain the goal of basal insulin. It's mainly to control that fasting blood sugar, providing a steady background insulin level.
Then discuss the types.
Yes, mention the newer long-acting analogs like glargine, Lantus, Bosiglar, Detamir, Levemir, though noting it's being phased out, and Degludec, Tresiba. Highlight that these generally have a flatter profile and lower risk of nighttime hypos compared to older insulins. The choice might depend on formulary, cost, patient preference. Yeah.
And the starting dose.
Typically low, around 0.1 to 0.2 units per kilogram of body weight per day, usually taken once daily, often at bedtime initially. Emphasize it's just a starting point.
Patient education seems like the absolute cornerstone here.
Non-negotiable. Injection technique, where to inject, rotating sites. Storage, keeping it cool but not frozen. Recognizing and treating hypos is critical. How to use the pen device. Checking the insulin, looks right clear for the analogs, uniformly cloudy if MPH were used.
And how to adjust the dose, titration.
Right. Teach simple titration based on fasting blood glucose. For example, check fasting sugar for 3 days. If it's consistently above target, increase the basal dose by, say, 2 units. If it's too low or there's a hypo, decrease it. Do this every 3-4 days until the target is reached. Keep it simple and provide clear instructions, maybe written down.
What about the other diabetes meds if we start insulin?
Good point. We need to review them. Often we'd reduce or stop the sulfonylurea, like glycoside, to minimize hypo risk. Metformin is usually continued. SGLT2 inhibitors or DPP4 inhibitors might also be continued depending on the situation.
And involving a diabetes nurse educator sounds ideal.
Absolutely. They are invaluable for that detailed education, technique checks, and ongoing support. Referral should be standard practice if available.
And circling back to Mr. Tan's fears, making it a shared decision is key throughout this whole process, right?
Totally. It can't be us just telling him what to do. We present the rationale, discuss the options, address his specific concerns directly, provide resources like those health hub guides, and then decide together on the best plan for him.
So, summarizing the big picture for managing patients like Mr. Tan, what are the main takeaways for our residents listening?
I think it's 1, do that thorough assessment, really get to the bottom of why control is poor. 2, address fears and concerns, especially about insulin, with empathy and good information. Don't shy away from it.
3, maximize non-insulin options first, focusing on adherence and lifestyle, maybe adding another agent. But 4, don't unduly delay basal insulin if it's clearly needed to reach goals and prevent complications.
And 5, if you start insulin, prioritize comprehensive patient education, clear titration plans, safety netting for hypos, and ongoing support. Make it a partnership.
So for all of you managing these patients, dig deep on adherence, give practical, culturally aware advice, tackle those insulin fears head-on with good communication, and feel confident about the nuts and bolts of starting basal insulin, always keeping the patient central.
And remember, those resources, the guidelines, Health Hub, your DNE colleagues, they're there to help you and your patients.
Finally, something to think about after this discussion. How can we get better at identifying and addressing these patient anxieties and barriers around insulin much earlier, maybe even before their blood sugars get quite as high as Mr. Tan's? Worth pondering. Thanks for tuning into this deep dive.